This is a great group we have here. And I mentioned, if you were in the big room, about awards that we give out every year for the best health plans in America. And these people really deserve a lot of credit, right? They're going against the grain. They've been, told for a long, long time, the entire world is this box and you need to stay in this box. Really up and down the line with our panel, they've taken a step out. And so, as we talked about, love to have questions as we go through. I think there's a small enough room. We can keep it pretty informal, including the panelists. You want to grab the steering wheel a little bit and steer in a different direction, please do. But I think we'll just, why don't we start with just introductions of who's on the panel. And I'll start with just, again, contextualizing. We're going to highlight one of the winners of the Rosies, which we have the CFO of the Hospice of Wichita Falls. And one of the things I'm really excited about, and I should have made a bigger plug in the main room, but I got distracted, is I talked about walk the talk. A lot of times I'll be talking to people in the healthcare field, and they'll be commiserating about how bad the system is, and certainly, as you heard those legal cases, you heard about Chris talking about overpayment by the carriers. Is there anybody in here who's ever gotten overpaid by a carrier? It only happens to the big health systems, right? The independents have gotten the table scraps on that. And so that is one of the things where then I'll ask them, hey, what do you do for your employees? And like, Blue Cross or blah, and like, whatever. I'm like, okay. Don't you think that's a little bit of a contradiction? Well, they think they didn't have a choice. My own organization, when we started our own employee health plan, we had 7 people. Yes, we couldn't do everything that we would want to in the Health Rosetta Blueprint, but we could do a lot of it, and each year we can do a little bit more. So even a very small organization can take meaningful steps in that, and I think it's important that clinical organizations are taking the lead on that and being an example. So Hospice being one example of that, they are in the healthcare field, and so it's particularly impactful when you have an organization that is in the healthcare field walking the talk. So why don't we start with Derek? Why don't you introduce yourself, your organization, your role, and then we'll go down the line and hear from the doc and the benefits advisor.
Great, thanks, Dave. So Derek Francis, I've been the CFO at Hospice Wichita Falls. It'll be 8 years next month. So about Hospice Wichita Falls. So for those of you who don't know, Wichita Falls is a town just across the Oklahoma-Texas border, about 2 hours, a little bit more southwest of here. Just take I-44, it's where I-44 ends. So we're a town of about 100,000 people, and we're by far the largest hospice in Wichita Falls. We serve 12 counties in Northwest Texas. At any given time, we're taking care of between 250, 260 patients. We've had a 12-bed inpatient facility for about 30 years, and just this last October, we opened a new 24-bed facility. So it's a great organization to work for, very proud to work for. We have an incredible reputation around town, and now a health plan that we can really be proud of. So we have about 215 employees. At any given time, I'm not sure how many belly buttons we have on the plan. I think it's less than 200. So that'll kind of give you an idea of the size of company we're talking about. But as we go on, I'll kind of talk about what prompted us to make the change in our experience so far.
Is it on?
Yep.
Okay. I'm Dr. Jeff Swanson. I am a TCOM grad from Fort Worth. My wife and I, Dr. Teswick, who's actually minding the shop as I'm here, we opened a DPC practice about 3 years ago called Stratos, Direct Primary Care. This is our 28th year of practice in general, so we've been doing a lot of different things in the meantime. So we've kind of been on the traditional side and on this side, and we see the difference between volume and value. And we actually have gotten together with a lot of local community leaders, but also a lot of the companies in our town, trying to find ways to improve the care for their employees and keep them at work and so forth. And so we are part of that big, like also trifecta kind of thing, that we actually have worked together to make this plan hopefully a model for other people. So.
And I'm Kelly Fristoe with Financial Partners. That name, Financial Partners, is one of the things I always have to describe, because a lot of folks look at that name and go, oh, you guys are like an investment firm or a retirement planning firm. And we have some people in the firm that actually do that, but the name Financial Partners has to do with, we actually try to live this concept of partnering with our clients and helping them make smarter financial decisions in the purchasing of their health care. And so that's the name Financial Partners. We've been in business for about 25 years and specialize in this space of healthcare financing. We have a large block of Medicare business. We have a large block of Affordable Care Act marketplace coverage. And because of the size of our town, there's not a lot of large employers. And so we have a pretty significant block of small group, fully insured business that I'm hoping very soon we will be able to use some of the tools that are available and scale down what we do for a large employer down into that small employer space and then create those solutions there. I'd also be remiss if I didn't introduce to you guys one of the fellows in our agency, David Cook, who is also primarily responsible for us obtaining this client, Hospice of Wichita Falls. He's the one that had the introduction. And then we got together and worked through building that health plan through the Health Rosetta program and built a high-performing health plan.
Great. Now I want to get from Derek and Kelly kind of maybe, each side of the same coin on, going back to those steps I had in the deck of, like, at some point you decided to choose a different path. What went into that? What were the barriers there of just even being open to something that's not just your standard Blue Cross, Cigna, Aetna, whatever? How was that kind of mindset shift happening? Was that a quick thing, a multi-year thing? And then I'll pass it to Kelly to kind of describe a little bit of how that was facilitated.
So for us, it was, something I can point to, very real. It was a change in some of our upper leadership, specifically our HR director that was the health plan administrator prior to me. And Stabby, if you've heard this one before, right? It's renewal time. They come, you have your meeting, they come in, and in our case, it was one of the big ones. You could probably guess. And had a really, friendly relationship with these folks. They still send us Christmas cards, which is hilarious. And they're probably like $8 a piece Christmas cards. This year it was like all AI or one picture. One was the guy's family, and then you flip it, they're all in goofy Christmas outfits. Anyway, they were very friendly and very nice and had a really buddy relationship with the old HR director. And so when we would have our renewal meeting, they'd come in, they'd give you their fancy packet. And, across the spectrum, you'd have, over here is fully insured, which of course is where we were. And over here is, self-funded, full RBP. And they would spend the whole meeting, telling you why all of these options, but specifically way over here, would not work for us either, because, this year might be that we're too big, or this year might be that we're too small. The healthcare landscape in Wichita Falls, we only have one major hospital, and they would never play with any of these plans. And so, fortunately, guys, it's going to be a 25% increase again this year. And so after about 3 years of that, it became really unsustainable. So I was kind of screaming, hey, not necessarily for a new broker. I mean, we didn't know what we didn't know. We just knew that we couldn't continue to do that. So about the same time, now, how many years prior had you reached out to that person to try to get a conversation going?
So there was a conversation probably 6 years ago that a board member had brought me in, and the HR director at that time said, "Oh, we will never do business with those people because of those things."
Right.
And okay, well, so we have a chance.
Right. So it was 2020, and I was just wrapping up my financial statement audit that spring. And my auditors, who I have a real good relationship with, said, "Hey, do you know Kelly Fristoe and David Cook over at Financial Partners?" And I said, "No, never heard of them." They said, "Man, y'all's health insurance, just like everyone's, is going up and up and up. You should talk to them." And with not a lot going on that summer of 2020, I mean, it was really kind of unremarkable. We started talking with Kelly virtually. It was too late. It was too late in the plan year then. But we knew this is going to have to change, and so. We were fair with our old broker and told him, "Hey, we're going to have to do something different next year." I was very, transparent with him. This is not going to work for us. So start working on one of these things. And we never heard from him again until it was time for the renewal meeting. And about that time, they got what's the official form that we were, basically firing them and changing brokers. And oh my gosh, it was. But by that point, it was way too late, and we were pretty far down the road. But I'll turn it over, and you can kind of tell your side of that.
So I don't remember what year it was, 2016 maybe, when I first met Dave in Dallas at a Health Rosetta event. Read the book, and I thought, this is some incredible stuff. I need to go to confession, and I did, and I started. Just educating myself more on what this high performance plan looks like, getting away from the fully insured plans, which I think, frankly, and if you look at this the same way I do, I truly believe that in a very short period of time that these fully insured plans, they're going to be the new risk pool, because more and more employers are going to, be driven out of those plans into something that they can go and be underwritten in, whether that be level funding, whether that be some sort of a captive, or whether it be a partially self-funded plan where they can get relief from all of that perverse stuff that occurs in those plans. Long story short, we read the books. We also read the Marty McCary book. So if you guys haven't read that, was at one point kind of the industry Bible. Then there was the Marshall Allen book that came later, Never Pay the First Bill. Anybody read that book? So if you have, that book will kind of really get you a little upset when you start reading the pages of what the healthcare system is doing to the community. And we just went and took a couple of those books and we gave them to leadership and said, "Here, read this book. It has a lot of great information in it. We're going to come back and talk to you about how to solve some of these problems using the Health Rosetta model." And that's what we did. And it worked. And we were able to take a group that had a fully insured plan that with a company there in Texas, they have a blue logo. Y'all probably seen it before. And not to mention any names, about $6,000 deductible, probably close to $900 a month was what their renewal was going to be per employee on a fully insured chassis. And we were able to take this health plan, and the timing of whenever the doc came out of the corporate clinic to open up the DPC was perfect, because it coordinated with the renewal of this plan or the implementation of this high-performing plan. So we're able to get DPC in there right away and build that into the plan to where the employee now has around a $1,200 deductible, and the premiums went from around $900 down to in that $400 range, saving a ton of money. So swing back to you guys, or Dr. Swanson, you want to?
Well, let's get into the meat of the plan, right, and the primary care and all that. We're not going to spend a lot of time on the optimized plan infrastructure. That's probably not that interesting and go into a lot more detail. Though the one thing that people always ask me when an employer is talking to me is like, "What's the first thing I need to do?" Which is what they did: hire the right benefits advisor broker. And it's worth also calling out one thing with Kelly in that, and the point is, we all have not only our local impact we can make, but we're part of other organizations. Kelly was recently the president of the trade association for the industry of benefits brokers. And he played an incredible role on really transforming that organization to this new world. I mean, candidly, that was an organization for what we were doing, wasn't viewing them as helpful. And some of the stuff that was talked about in the CAA wasn't helpful. it is a transformed organization. I'm sure there's plenty of internal challenges I'm not aware of, but Kelly and the other leadership there deserves huge credit. And I'd take that upon yourself. Every one of you has that opportunity today or in the future to influence organizations. And he did a wonderful job, not only impacting at that client specific level, but at a nationwide level. So there's hopefully a lot more Kellys around the world, around the country. So I think we'll just jump to the pharmacy, maybe do kind of a lightning round on what's happened, if anything, on the pharmacy side. And then let's get into really the care side where we can spend the bulk of the rest of the time. What happened on the pharmacy side? I mean, that's actually the most common touch point for most people with the health plan. And it's also the one where, as was mentioned earlier, CVS Caremark's so big they could buy it, and it was not exactly a small organization. So what happened on the pharmacy side? Are there any things you've been able to do?
So, I mean, our PBM was Southern Scripts. They've changed the name to Livinity. I mean, the impact for our members, and this is just one part of it. I mean, as Kelly said, the cost was super high. So, we took care of individuals, but for, anyone to have their family on was close to $1,000 a month. And the last year, I felt really passionately about it, from the whole time I'd been there, that this is, I'm not proud of this health plan because we have people that do the hardest work, the CNAs, that really drive our mission. And how am I supposed to look at them with a straight face and tell them, oh yeah, we offer health care for you and your family? No, we don't. And even if they did get it, it was a joke. It was a high deductible health plan. It didn't cover anything. So the prescriptions specifically, though, Dave, are way better. I mean, on our high deductible health plan, it covered 100%, right, after deductible. So until you hit your 6 or 12,000, yeah, they were paying full board at the pharmacy, even for generics. So yeah, we were good RXing people and jumping through every hoop that we could to try to get costs down for members. But now zero for a lot of generics. Most everything's 25. One of the things that the health plan has allowed us to do that's impacted me personally, from a health standpoint, is have full control over our prescriptions. If somebody, I mean, I'm not going to mention any names, goes to the doctor and has a conversation with them about health, and they've been overweight their entire life, and they say, hey, there's these new drugs out to help that. As a health plan, we can make that decision. Okay, so do we want to not pay for this and let that person get diabetes, and then we're going to be paying for it anyway, or maybe not pay for it for 10 people, and we know that if one of them winds up in the ER, has a heart attack, it would have been cheaper to pay for it for all 10. So just little things like that allow us to have full control. But yeah, from a member standpoint, it's outstanding on the pharmacy, but for the overall plan as well, just from a cost standpoint.
Well, also, you mentioned how the big guy here get a free five back.
Yeah.
Likewise, have the rebate that they'll put money back.
Yeah, I believe it's quarterly. Yeah, we'll get a rebate check. The PBM, we'll send off, all the manufacturer rebates for all the drugs that our members have used. But, it's no surprise. I mean, I was looking at the report last week, and, prescription costs is definitely, up there at the top. So, but yeah, definitely light years better than what we were doing.
Great. Well, let's dive into what happened in primary care front. Maybe start with Jeff in terms of how did this surface to you? How has it been from the clinician side of things in terms of working with somebody like Kelly, how you started working with employers? Were you working with a lot of employers before, or was this early in that journey for you?
Yeah, so my wife and I had a dream. We had done the corporate world for about 25 years and I was in the military for a while, military medicine. We did house calls for Medicare. We worked for different employers over the years. And our last employer was the main hospital there in Wichita Falls, and we were there for 10 years. And at the end of the 10th year, we had decided that we were done with medicine. And I guess we were going to move to Florida and sell fish. I wasn't sure what we were going to do, but we were done. Medicine had burned us out. And so one of the local doctors there in town had started a direct primary care practice, who's still there in her 6th or 7th year. And she said, Jeff, you guys got to do this. I'm telling you, if you do direct primary care, you're going to love medicine again, and you're not going to quit. And I was like, I don't even know what direct primary care is, whatever, concierge, we're not really sure. But anyway, she took us under her wing. And in, I'd say April of 2021, we went to a mastermind for DPC, which is, they have them all over the place now, but you can go and learn about direct primary care, about physicians who've done it. And what we found out was that's the way we should practice medicine. It's what we got into medicine for. Take care of patients, spend time with patients, more value than volume. And that was the difference that I realized real quick with DPC. You get value and it's not a volume thing. And so we decided in April we would resign from our positions and we would plan for the next 6 months to develop a DPC model practice. And somewhere along the line, I would say somewhere maybe in August, I would say of that 2021 is when Kelly approached us and said, listen, I hear you guys are going to start doing DPC. I have a client. We're like, okay. We're figuring 5 or 10 people, something like that. Oh, no. There's like maybe 80 or 90 and there's dependents. And I was like, okay, we haven't got a building yet, but okay, that sounds good. And so over the course of the next 6 months, we had done the open enrollment in November, and we opened our doors in January the 10th of 2022, and we had 350 people on the enrollment all ready to go. So we started hitting the ground running in the sense, but we fortunately had that company, along with a lot of our patients who followed us over, to enable us to start the program effectively and economically feasible. And then from that standpoint, we grew, and within about 8 months, we were full. We had not only this employer, but we had probably about 5 or 6, I think, right now on our current active roster. So about half our patients are individuals, family members, and then the other half are basically employees or employers. And initially what we saw was that people couldn't afford the insurance plans. Now it's the companies can't afford the insurance plans. So for the doctors that are out there, for the medical students and residents, if you continue down the same path that everybody else has been doing, traditional medicine, it won't last. It is imploding one way or the other. So the only way forward is to try to do something along DPC lines with these types of plans, because it becomes affordable, and the patients, and you can speak for it, they actually are like, this is the best care I've ever gotten in my life.
Yeah, and just I know we have some medical students and residents, and obviously you were out in practice for quite a while before that, but I think it's worth mentioning that I have seen numbers of new docs right out of residency. They, a lot of people, like in the case of primary care, tried to steer them away from primary care because it's become miserable in the fee-for-service world, and they just said, "Nah, I'm not doing that." And more, because of the growth of DPC, there are some practices that want to bring in new docs. That's happening, which is great. That takes some of the risk off the plate. But even in those instances, particularly some of the early ones, they're like, I'm not doing that fee-for-service thing. And while they built up practice, they might do some time in urgent care or ER or whatever as they built up their book of business. Fortunately, more and more, I think one of the ways to look at this event, one of the ways to look at Rosetta Fest, which is the event we have, is it's kind of a market-making event. Bring together the buyers and sellers. And as I mentioned in the prior session, it doesn't take that many lives to make a doc whole in terms of having a good practice. So, Kelly, why don't you add a little bit on the perspective from your how it went, how it's going, and and then love to hear from Derek's perspective on, from the employer and members' perspective.
So truly it was a blessing that Dr. Swanson and Dr. Teswick, the timing of them coming out and beginning their DPC practice for this group truly was a blessing. Because when I think about what's going on in the community where we live, and there's a slide, I don't know who has the clicker, but there's a slide that I've got.
Oh, yeah.
If you keep going.
Forgot about this.
Right there.
Yeah.
So where I've got the red circle is where Wichita Falls is. And this is the quick example. On the left, you're going to see a map of Texas back in 2018. And this is a map that looks at the companies that offer individual health insurance marketplace plans in Texas. There's only one company that does business in the entire state of Texas. But you'll see that Texas at that time, back in 2018, there were counties that also had 4 or more companies. Fast forward to 2024, and where I live is only one company that is able to offer health insurance in that market. All the rest of the state has adopted, or healthcare systems have worked with the other insurance companies offering those plans. It shows you that our community is not an early adopter community. They are a very difficult healthcare system to work with. Even the insurance companies, the Buca insurance companies, are having difficulty working, with the exception of one. So when we talk about healthcare and getting in to see our primary care doctor, and there's another slide as we go forward. The other day I was on the hospital system's website, which is my chart, that I can try to schedule an appointment to see a physician. And whenever I went to that system to schedule an appointment with the physician, the first available time that it gave me was February the 18th of 2025. We're seeing this theme that you guys have heard in other breakouts in the main stage of an access issue. We are having an access issue because if my wife says to me, well, Kelly, I was in the shower, I feel a lump in my breast and I think I need to go get it checked out. I'm like, yeah, you do. And she can't get in until February the 18th. So today, if she was able to get in, that could be maybe a stage 1 that we've caught early and can be treated quickly, inexpensively, and she can still be here with us. But by February the 18th, that very well could be a stage 4. We're talking life and death here. And for you doctors, or soon-to-be doctors in the room, these healthcare systems are saying to you they want you to see 4 patients an hour, also known as the 15-minute rule.
And then 2 hours of paperwork for every 1 hour of
exactly. So I think
time.
that you physicians, I hope you don't take this the wrong way, but where Dr. Swanson is talking about what was taking place in that corporate clinic and what was leading to burnout was that he was being prevented from truly practicing his trade of improving population health and becoming nothing more than a healthcare traffic cop. 15 minutes referring to a higher price specialist within the same healthcare system at a much higher cost to the patient. Very perverse things that were happening. Don't be that. Let's fight that. So for you doctors, if they ever tell you you've got only 15 minutes with the patient, something's not right about that. So,
yeah, I mean, it's like it's not primary care when it takes that long to get in. And you know, I wrote the seminal paper on direct primary care about 11 years ago, and was starting to chronicle the direct payment, direct care, what became the FMMA market, and it was a lot hard to do it. I'm not saying it still doesn't have challenges, but we're a lot further down the road. There's a lot of lessons that can be learned from other doctors. You got these mastermind groups, so there are some great resources for folks. So, Hint has all kinds of, for folks who are doing the direct care, all kinds of resources to help people ramp up. You mentioned I should have had this up as you went by it, but yeah, this is real, and one of the saddest stories that I've heard from Health Rosetta advisors was a Health Rosetta advisor who his aunt, she was afraid of the healthcare system. She was having all kinds of symptoms, but she I can't go to the doctor. She worked at Denny's, had a super high deductible plan, and didn't tell anybody anything was going on until she was hemorrhaging, and she had stage 4 cancer. It was a cancer that could have been caught earlier. That is happening all the day. This is a different form of rationing that we're doing right now in today's system. So we're getting down to the end. You spoke to this. You want to add anything?
Yeah, I'll just give you some examples from a primary care standpoint. So this is not uncommon to have this in our regular DPC practice. Patient sends you a picture, and it's basically on the side, and it has a classic case of shingles. And they say, I have this rash. It's been there for a day now. It's starting to really hurt. I'm like, okay, shingles, that's what that is. Here comes your Valtrex over to Walmart. Pick it up. Good to go. In less than 5 minutes, they got diagnosed, treated, and they're done. In the usual world, they would say, well, I call my doc. They'll say, well, I can't see today. Go to walk-in or go to the urgent care or go to the ER. So they'll go to one of those places, they'll sit there for who knows how long, and they'll get a bill for $2,000 or $3,000 later for the same treatment. Maybe they got misdiagnosed even, but they'll get a treatment and then they'll go home. And then they miss work or whatever. So one of the things, and I know Derek can speak to this, is that a lot of our folks, when they do call, they get diagnosed quickly, treated fast and effectively, and get them back to work as soon as possible. Because that's less time for the employer have to take that person out of shift and have to replace them, cost them more money. So the idea of working with providers or employers is to give them the opportunity to keep their people on the job, keep them working.
And we've seen the utilization go up too from word of mouth. Me personally, I mean, if I find out someone's not going to see Dr. Swanson or Dr. Teswick, I'm like, what's wrong with you? Because our plan covers it. So already done a little bit of the plan. So yeah, as Kelly mentioned, it's $1,250, $2,500 is your out of pocket, your deductible. For the single member, it's $75 a month. Family goes up to $550. Okay, so it's not cheap, but it's still significantly better than it was. And then $2,500, $5,000 on the family, but we pay for all the members DPC. So this is $75 a month on average that we pay Dr. Swanson or Dr. Teswick. The plan pays for it. So me as the plan administrator, I get all my primary care taken care of for $75 a member, which is great. But then I turn around and put on my member hat. I get access to Dr. Swanson whenever I want for free. And so the first year, yeah. So the first year, it was just the primary members. And then when we renewed for the second year, it's really been the only change we've made to our plan. We said, hey, if they have dependents on there, put them on there too. Who cares? We talked to them. They were great with that. And so we pay their DPC fees as well. So yeah, it's great.
And I'll have my own experience on speaking of shingles. Our very first Health Rosetta event, November 11th, I think 2018. I remember that day because that was the opening night of our reception before the event started. That was the day my dad passed, and that was the day I was diagnosed with shingles at the opening party by a DPC doc. I was like, man, there's something that's really bugging me here. And he's going, you got shingles, pal. I'm like, oh, I wonder why. No stress in my life. And, ran down to the pharmacy before it closed. So that's DPC docs are great, even though I wasn't his patient. He took care of me. So I know we're writing down. Any final comments any of you want to make in words of inspiration for everybody?
Yeah, I just wanted to say that last slide there. Really, I think this is the only type of plan that you can put together that will solve all of these problems that we're having in the industry. Derek we mentioned a little bit about premiums and plan benefits and design. The first year that they had this, and there were some significantly high claims. So there was a liver issue that took place that first year. They had some claims that were tough, but the first year, the plan saved from what their renewal would have been over $600,000. The second year, they didn't have a rate increase. Rates held. And in the third year that we began in October, there was a decrease in the premiums. So this works when you build the right kind of plan and you have a good teamwork. Nothing here requires anything big, like a big agency out of the big metroplex with 200 agents that are going to work in this case. All it takes is the human resource department, the employees, the practitioners, transparent TPA, and the transparent consultant and broker, all working together as a team. That's not big. It's easy to do.
I'll just say, I'm glad we didn't know what we didn't know. Several of you, talking in here, they're like, wait a minute, you went from fully insured to completely full RBP, no PPO network, no nothing. I'm like, yeah, I know, it's crazy. And we didn't know, what a big change we were making. And that's probably a good thing. But I'll just tell you that, first of all, with our company, we're an older demographic, very tender, caring people. We're not big fans of change. And so, any change that we make, people are going to grumble. But this was a big change. And, Kelly uses the analogy, when you're fully insured and you're paying high prices, it's like you're doing your grocery shopping at 7-Eleven, right? It's convenient. You know what you're going to get. It's not going to be the best quality, but it's going to be easy, right? You're just going to stop, get out of your car, and be right back in. And Where, what we do now is, I think he compares to Aldi. It's a little bit more of a pain. You got to put your quarter in the shopping cart, but you get a better quality product at a lower price. But they don't, and when you do it, don't expect it to be perfect, because it won't be. The first almost year of our plan, we had no agreement with the hospital. And so what did that look like? Well, our members were getting gigantic balance bills, right? Most healthcare systems or providers, will the way RBP works is they send a bill for, billed charges. If we don't have a direct agreement with them, we consult the plan document. It says 130 or 160% of the Medicare rate. They get a check within 2 weeks. Most of them say, that's good enough. But some of them, not mentioning any names, our big hospital system says, nope, sorry, the different, just back there just dying. He works for the Kipton Group, and he helps negotiate the agreement. So anyway, the hospital group would say, no, we charged $30,000 for this procedure. The plan document says that you paid $5,500, and so we're going to go back to the employee for the other $24,500 and send them to collections and all that stuff. It's called being balance billed. I'm sure you all know what that is. And so it was fighting through several of those, and then finally getting the attention of the hospital brass to get meetings with them and sit through them. All that to say, to come out with a really unfavorable agreement, but it's an agreement nonetheless. And so we steer as much business away from there as possible, and we're really good at doing that. A lot of people coming up to Keith Smith and having stuff done at Surgery Center of Oklahoma. It's easy to steer them, right? No cost to them. And when quite honestly, I think everyone in Wichita Falls knows better care. But for the members, if they have to use the hospital, they can, and they won't be balance billed. But
Yeah, the paradox in this is the best way to slash healthcare costs is to improve care and improve benefits. And Jeff, you want to have a final word before we let her rip?
From the standpoint, this whole system works with everybody kind of pitching in, doing what the best job they can do in their specific situation or field. But for the physicians that are out there in training and those that are graduating, you should consider this DPC and tell your friends, because it used to be that you go into specialty care because you can get paid more and pay back those expensive loans or whatever. But I will tell you, after doing DPC for 3 years, if I would have done this when I came out of residency, I probably could have bought the hospital in Wichita Falls. The amount, the time, and I don't mean that from making all this money. What I mean is, I could have paid my loans off easier than what I did over 10 years with military and other scholarships. At the same time, the patients and the people that you become friends with, the resources they allow you to make yourself available to you. Like, we have a cardiologist who understands DPC. He loans us his technician for free. He reads the echoes for free. All he has to do is pay the echo Medicare rate of $195 for the echo, and he does the rest. I'm like, you can't get an echo in Wichita Falls for less than $1,000. If you can get one, I can get mine the same day. So that kind of stuff, when you think about how much money you save people, that's what I mean. I could buy Wichita Falls Hospital, because the amount of money you save for all these people is just astounding, and they're happier with the care. So think about primary care when you're family medicine kind of thing. If you're looking at doing medicine in general, you'll enjoy it. It is actually very fulfilling.
Great. Well, thank you for doing what you're doing.
Thank you.
And we'll let you go.